All right, we're back with another article from LLSA 2021 Emergency Medicine. This is Managing Peripheral Facial Palsy. Let's just call it what it is, Bell's palsy, by Garo et al. Matt Delaney is going to walk us through what do we need to know about something that we see very, very often, the stroke that isn't, right?
That's exactly right. We see this all the time. Almost every time I see a case of peripheral facial palsy, I have to stop and look it up. So I think, how do we make the diagnosis? What do we do with this diagnosis? I think this is a really good review. So generally, we're talking about a cranial nerve 7 neuropathy. There are a lot of different things that can cause this, so we have to really keep a broad differential. And then what we do for these patients from a diagnostic standpoint can be everything from I look at you and get a story and I know what's going on to I get an MRI to try to figure it out. You know, when we talk to these patients, it's very distressing for the patient because their face is drooping, their eye might not shut. And so the authors start out right away by saying this is a common problem. And sometimes the problem sticks around for a while. So when we talk about likelihood of recovery for patients, 70% of patients have a full recovery. 15% have partial recovery and 15% have a permanent palsy. And I think that's a helpful reminder that this is not necessarily something we can fix in all of our patients.
And I will do that when I'm talking to my patients, Matt. I am going to tell them, I'm like, because like you said, they're distressed, but I'm going to tell them this is very common. You are most likely going to get better. And I'll give them the time course of weeks. And I will add that, hey, sometimes it lasts for months, just so that they're kind of set up for if it's, they're like, well, they said it's going to go away and it's still here 2-3 weeks later, they're not stressing out about it.
Yeah, it's a good reassurance. So shifting into how do we make this diagnosis, the history and exam, the single most important thing, and this is what I always have to look up and remind myself, is this a central nerve palsy, so a stroke or something bad, ominous, or is this a peripheral nerve palsy? The separation here is going to be that a peripheral nerve palsy is going to involve the forehead, where a central nerve palsy, so a stroke, is going to spare the forehead. Now, the neuroanatomy here is a little complicated, but basically the forehead is innervated by both cortexes. So if you have a stroke, you're going to get some coverage in the forehead in the innervation from the non-affected side. So it's a little counterintuitive because if I look at a patient and say, oh gosh, it involves your whole face, it involves your forehead, that actually is more reassuring. That is strongly predictive. Actually, that's diagnostic of a peripheral nerve palsy if the forehead is involved. Whereas if I look and say, oh, thank goodness, it's your face is drooping, but your forehead is okay, that's when we should worry. That is suggestive of a central nerve palsy. Other things to pick up is preceding symptoms. The authors don't give us a lot of reliable things to look for here. Patients will sometimes say, my face felt a little tingly or my eye was watering a little more than usual. The authors point us towards travel history. And really what we want here is a history of tick exposure, and we'll jump into that in a couple of slides. And then associated symptoms. So if a patient says, my face is drooping and I can't walk or talk, boy, that sounds more like a stroke. So really when we're thinking about a peripheral nerve palsy, it's going to involve the forehead, it's going to be a facial droop, there are not going to be a ton of other associated symptoms. This is a good graphic representation of the difference between peripheral and central pulled right from the article. So you've got peripheral there. You see the entire side of the face that's affected is flat. The forehead is flat. There's no wrinkles. They can't move their eyebrow. They have trouble in a lot of cases closing the eye. They got the lower face droop as well. You contrast that with the central side where the lower face is drooped. The eye may be affected, but the eyebrow, the forehead can still move. They may have some wrinkles that cross over there. So again, look to the forehead. That's going to be our guide. Now, to muddy the water a little bit, you can get an incomplete peripheral nerve palsy that will only involve the lower face. You don't get the opposite of that. So if you ever see a patient and the whole face is involved, the forehead is involved, the lower face is involved, that is a peripheral nerve palsy. No questions asked. That's not a stroke. And that's when you can stop and move on to past diagnostic and more into how do we treat these patients.
What I'll do in my exam for these patients to kind of accentuate that forehead, Matt, is I will ask them actually to raise your eyebrows, and I'll also ask them to try to squeeze their eyes shut and smile, and it just kind of helps bring out and accentuate the differentiation between those symptoms. If they are unable to raise their eyebrow and they are unable to close that eye tight when they're doing their smile, that really kind of puts me into that peripheral neuropathy as opposed to, like you said, a stroke or something central.
The first biggest pearl, and honestly, this is probably the biggest pearl of the entire article, is that if you suspect that they have a central facial palsy, we need to consider neuroimaging. And I would say actually just get neuroimaging on these patients if you think there's a central nerve palsy. Again, this is takes a little getting used to, because if you look at it and say, gosh, this seems peripheral and the forehead is involved, you don't need any kind of imaging. You're just done. But if it's a little bit unclear and you think central could be on the table, big pearl here, get neuroimaging.
It's also a good reminder, Matt, that when we're seeing these patients, your exam doesn't just stop at that facial stuff. I'm kind of doing a neuro exam, a stroke exam on all these patients, whether or not I think it's Bell's palsy and like a slam dunk, I'll still add that kind of stroke neuro eval so I can chart it, but also make sure I'm not missing the funky ones like you were pointing out.
We keep talking about Bell's palsy. So really, when we look at the causes of peripheral facial nerve palsies, these authors point out that it's not all Bell's palsy. So typically we talk about a Bell's palsy and we're thinking about, is this some kind of herpes virus that's causing this? Now, we use that term Bell's palsy to describe these physical exam findings, but obviously there are other things that we have to think about other than a herpes virus that would cause this. So one of the big ones, the authors hit this again and again in this paper, is Lyme disease. About 25% of cases of all peripheral facial nerve palsies occur in areas that are endemic for Lyme disease. I'll show you where those are in just a sec. And then that's a really important key, because if we're in an area where Lyme disease is endemic and we see a peripheral nerve palsy, what we do from a diagnostic standpoint and a management standpoint is going to be unique, as opposed to if we see a peripheral nerve palsy in an area that does not have endemic Lyme. Other causes to think about, Ramsay-Hunt syndrome, right? This is, remember, varicella reactivates out of the genticulate nucleus. So this is, you're going to see some vesicular lesions, local trauma, neoplasm. We think of things like acoustic neuromas, and then sarcoid can also do this. But the big players, number one, Bell's palsy. Number two would be Lyme disease. Lyme disease can be anywhere. You see every little blue dot represents a confirmed case of Lyme disease, but really look at the areas that are deep, dark blue. So when I lived in Maine, we saw Lyme disease or some manifestation of Lyme disease on every shift. To clerk out in California, I think if a facial nerve palsy comes in, you're pretty much in the clear from a Lyme standpoint. It's very unlikely that's the cause. But so depending on where you practice, you have to really listen when this paper talks about Lyme disease, or you can say, yep, that's a fun fact, but doesn't necessarily apply to me.
Yeah, this is something I used to not do, Matt, and after reading this, I was like, oh, I should probably add that, because you're right, we don't really have a whole lot of Lyme disease in California, but we do have some. And I just feel like it's one of those check boxes in my history that I should at least go through it, because 25%, like, that's a pretty big number when you're looking at patients across the country.
Yeah, I agree. And so that comes into play from the diagnostic standpoint. So the authors say, and I would agree, Bell's palsy should be a clinical diagnosis. So that is a patient that's in an area that does not have endemic Lyme, that has a facial nerve palsy. Now, if we're in an area with Lyme disease, or I would agree with you, we have to think about Lyme disease. The authors say to get 2-tier serology testing if there's greater than 1% risk of the patient having Lyme. The authors don't tell us how to get to that greater than 1% number. What I would say is that if you're in the Northeast, if you're in Connecticut, it's certainly greater than 1%. If you're in Southern California, if you're in Hawaii, if you're in Alabama, you're probably less than 1% unless that patient has a specific travel history. If you're in an area with greater than 1% risk, you do an ELISA test followed by immunoblot for confirmation. Now, number one, this might not be available rapidly in the emergency department. Number two, the initial test may be negative. And the authors say there's no need for an empiric lumbar puncture. And if you've practiced in an area where there's Lyme disease, that's really helpful, because what I was taught for years was, gosh, if they have Lyme disease and it's affecting nerves, then we need to make sure it's not in their cerebral spinal fluid. And what these authors point to is a couple of papers saying, no. you should test for Lyme disease on their blood. The only reason you need to do a lumbar puncture is if you think they have meningitis, and that should be kind of based on their history and their physical exam. So we don't need to do empiric lumbar punctures chasing down Lyme disease.
And from my end, I'll add like the question of any tick exposure or a tick that you found on your body, because it's rare that a patient's going to be bitten by a tick and not remember it or have been like, yeah, I had to remove that. And so because I have such a low prevalence where I'm practicing, I add that to it. And if it's negative and negative, I kind of almost can rule out Lyme for a lot of my patients.
Yeah, I think that's a good point. So that's diagnostics. So shifting into treatment, what the authors say is up front, if you think the patient has Lyme disease, you should empirically treat, waiting for tests to come back with doxycycline PO. The dose is 100 milligrams for adults or 4 milligrams per kilogram for children with a max dose of 100 milligrams BID for 14 days. And the authors emphasize that while we've been told, hey, be careful with doxycycline in children, there's actually a minimal risk of complication in children. So doxycycline PO is our first-line treatment. Corticosteroids are the first-line treatment for any case of peripheral nerve palsy that is not a case of Lyme disease. Now, we don't use these if we suspect the patient has Lyme disease. That's when we use doxycycline. But for all other comers, if they've had symptoms that started less than 72 hours ago, corticosteroids seem to be effective in terms of improving cosmetic outcomes. Now, the number needed to treat is reported to be as good as 8 and as high as 50, but I think it's a reasonable option. And the authors say, look, if you have severe symptoms, they don't categorize what constitutes severe, but I think you and I look at a patient and say, that looks pretty severe. If it's severe and it's been more than 72 hours, these authors say, hey, you might as well just use steroids. Now they point and say, hey, the efficacy here is unclear, but the general principle seems to be, if it's really bad, throw more medication at it. Again, do not use corticosteroids if we're treating Lyme disease. And the authors give recommendations for specific steroids. They talk about a methylprednisolone dose pack for adults, and for children, they talk about prednisone for a 10-day course. They're not high-quality studies to say that you have to choose these types of corticosteroids, but in general, we want to do a fairly decent dose of corticosteroids for a good number of days.
You know, Matt, as common as this palsy is, this is one of those things I have to look up every time is the corticosteroids, because like you pointed out, there's some details there. I did not know you should not be using it in Lyme disease. So if I'm suspecting Lyme, based on my history, because I'm not going to get my lab results, no steroids. And then that second part that you alluded to, fleshing out severe versus not severe. In general, I feel like the majority of people that are coming to me with a Bell's palsy, it's severe enough that it's concerning them. And so I tend to almost do steroids for all of them, regardless of that 72 hour. I don't know if that's correct, but I have a hard time like you in terms of fleshing out, well, what is severe and what's not.
Yeah, I would agree. If you show up in the emergency department and you're distressed by your symptoms, I could make a case that this must be severe. You came to see us. So you're right. There is some nuance in terms of what our treatment choices are supposed to be for these patients. Now, again, the big pearl here is that if we suspect the patient has Lyme disease, doxycycline is the first-line antibiotic, even in children less than 8. And the authors say the potential benefits of doxycycline may or likely outweigh the risks from this medication.
Now, this brings up another question for me in terms of the treatment, because when I think Bell's palsy, you already pointed out that, look, it's herpes viruses are very common. And so I'm doing, decision for steroids and then decision for antivirals. But now you're throwing in this, if it's Lyme disease, which is obviously not a virus, we're doing antibiotics. So what do you do with the antivirals? When do you make that decision?
So the needle has gone back and forth over the past couple of years about, do antivirals help? And what these authors say is that there's no evidence that antivirals in isolation improve patient outcomes. Now, there are some papers that will say that if you have patients who have severe symptoms and you're treating them with corticosteroids, that if you add on antivirals, you get a number needed to treat of about 20, which is actually pretty good. These are pretty safe, well-tolerated medications. So severe symptoms, I'm thinking it's not Lyme. I'm going to treat you with corticosteroids. I'm going to throw on antivirals, and it could be valcyclovir or acyclovir for 5 to 7 days. So that's the role, is only with corticosteroids if we're not thinking about Lyme disease. Now, we talk about all the different treatments, all the different medications. One of the most important things we need to think about is, what about their eye? Right? They've got a facial palsy. They can't close their eye well in a lot of cases. And one of the big issues here is that because they're not blinking the same amount they normally would, or especially when they sleep at night, the eyes can dry out and they get ulcerations. And so this is the thing. It's easy to just write prescriptions for antivirals, but I try to sit down with the patients and say, look, you don't want to mess up your eye. So I write them for artificial tears and say, put these in your eye hourly while you're awake. And then I'll write them for some type of eye lubricant and an eye patch for when they're sleeping. And I've actually started trying to show patients, hey, look, here's a roll of paper tape. Show me how you're going to tape your eye shut or patch your eye, because that's a really big thing we can whiff on if we don't think about what could happen to that patient's eye.
Yeah, I think that's 100% true, Matt. We always are arguing about corticosteroids and antivirals and blah, blah, blah. But if there's one treatment I got to choose, it's going to be the eye. And I do exactly what you do. I sit there with the patient, show them how to tape their eye, show them what I want them to do, and make sure they understand that. And once I've done that, well, then I think about all the other stuff.
Yep, and just for spaced repetition here, the authors, their big last pearl and pitfall, they emphasize that corneal ulcers can and do develop if they don't properly lubricate their eye or properly cover their eye. Because again, most of these patients, even if they think they can close their eye pretty normally, actually aren't doing it as effectively as they need to protect that eye.
All right, a great review. Things that I learned. Bell's palsy is a word I use for all the facial paralysis, but it's not all Bell's palsy. I got to think about Lyme disease. 25% of cases in the United States are from that. That's a big eye opener for me. And well, we kind of go back to the discussion about, well, antibiotics, antivirals, and steroids, always a little nuanced. So if you forget, well, do what I do, just look it up, but don't forget their eye.
This is Hippo Education.